So board members, while they're getting set up, I wanted to introduce everyone. I'm going to start over here on our right. This is Jamie Turpin. She's the administrator of the PDMP. She's going to be giving a presentation today about the metrics that our pain committee has been using to determine prescribing practices. And then we have two members of the pain committee here. You have Dr. Carlos Ramon. He is actually the chair of the Pain Management Review Committee. And then we have Dr. Ronald Tilley. He's also a member of the Pain Management Review Committee.
And I guess this was just a question of just discussing the matrix and kind of introducing it because so many of us are new, James, so go for it.
Is this on?
No, keep trying. Is it?
It's
Okay.
on.
I'm so loud.
Is it green? It looks green. Thank you. Okay. Hi, Jamie Turpin, PDMP administrator. I'm just going to kind of go through like the background of how we got to where we are today and then answer any kind of questions y'all have at the end of it, if that's cool.
And Jamie, I just want to say, if y'all will go to your Zoom screens, her slides are going to be on your screen there.
They look good. They're upright. Did a good job. Thank you. Make sure I do. There we go. So Act 1208 of 2015 is the mandate that allows us to provide any kind of notification to a professional licensing board of problematic prescribing, as long as the board gives us the parameters to define that notification. So that was passed in 2015. I got here in this position in 2018, and we've been providing metrics since then. I don't know when my predecessor started. But here's some background on how we got where we are. So prior to me starting in this position in 2018, some of the lists that were provided were based on an individual metric. That metric could have been number of providers with the most patients with an MME greater than 200, or the provider with the most opioid patients overall. And it was kind of found at that time that that was not a very fruitful metric because the top 10 was always the same top 10. Some of it could be explained based on their practice type. So we started to think about how is problematic prescribing defined? Is it who's writing the most number of opioid prescriptions, who's writing the highest number of opioid solid dosage unit forms, or who has the highest number of opioid patients? So right before I started, some colleagues of mine went to a conference. It's the National Association of State-Controlled Substance Authorities. It's a conference they put on every year. And Ohio talked about how they were identifying providers using multiple metrics. And they had to have legislation passed so they can do this. So they could start investigations on providers. So Ohio had a list of what not to do. So the top 10 prescribers of any drug X, if we're looking at oxy-30s or fentanyl patches, regardless of what it is, they'll always be a top 10. Then they thought about looking at doctor shoppers. And the point they made was if a doctor shopper finds a criminal prescriber, then the doctor shopping is no longer needed. You have who you need to get what you need. So what factors can be unexplainable? So one thing we thought was high number of patients. Well, ER physicians probably see the most number of patients coming in and out, new patients all the time. You go to the ER, you're probably going to have some pain. So you're going to see opioid prescriptions. So they're going to have a lot of patients on opioids. Another factor was the high average MME per RX. Well, that was one that you could explain for oncologists or cancer patients, hospice patients, palliative care. Another thought was high day supply or high doses. That could be explained with chronic pain patients. So Ohio thought, well, what if we did, instead of one metric, we did a combination of metrics? So here's the metrics that Ohio developed and used. They had 7. The first one is the average morphine milliequivalent daily dose per prescription, total number of MMEs prescribed for that time period, number of overlapping opioid and benzo prescriptions from the same prescriber, number of opioid solid dosage units prescribed, number of opioid days supplied, and then number of opioid patients. And then the last one, which is kind of interesting to me, and I'll explain how they came to this, was if they had prescribed to more than 640 patients within 1 month. So you're probably wondering why 640. Their thought was if a prescriber worked 8 hours a day, they're just throwing that out there, and they worked 5 days a week, 4 weeks per month, and wrote an opioid prescription every 15 minutes. That would be 4 times per hour. That would be a total of 640 patients. So that's how they came up with that metric. So from those 7 metrics, what they would do is they'd identify the providers that were in the top 95th percentile of 5 of the 7 metrics. And there they have their list. And then instead of 5%, if you had 840 patients or more, that was considered, that metric was met. So their end result was they looked at their top 5 providers that scored high based on their algorithm, and they did investigations on all 5 of those. And if I remember correctly, their PowerPoint is posted online too. It was a very fruitful investigations based on these metrics that they developed. So when we saw this, we thought, well, we could probably apply something like this to Arkansas, but we need a little help. What's going on in Ohio may not be what's going on here in Arkansas, right? So we began having meetings with the pain committee back in, it was 2019. That was a while ago, 18, 19, late 18, early 19. I showed the same few slides I just showed y'all about what Ohio did. And then we had discussions on, of these metrics, what do you like? What do you don't like? Do you have any ideas of other things we could try and add? So what we ended up coming to is we were going to keep the ones in black, the average MME per day, the total MME prescribed, the overlapping opioid and benzo, and then change the number of solid dosage units total to the average number of solid dosage units per prescription of opioids. And then we wanted to look at the average age of a patient with an opioid prescription, thinking that younger individuals probably don't need as much opioid prescriptions at a time. That may be an identification of problematic prescribing. We kept the number of opioid patients, and then we added the total number of oxycodone prescriptions because those had a high street value. So if there was going to be diversion, we thought those would be diverted a lot more. We ran this analysis and came into some issues, specifically with the average age of a patient of an opioid prescription. If you think about the top 5% and we're doing age overall, it was identifying a lot of very young children and providers that were treating very young children. So it wasn't a very good metric for this purpose. So we came back thinking about it at ADH and the PDMP as to how could we change them a little bit more. And we came back to the pain committee, showed them some data of just kind of how it looked, and recommended that we keep the average solid dosage units that the pain committee suggested and the total number of oxycodone, 30 milligrams. And we just suggested keeping the 640 patients per 1 month. After conversations with them, our final solution or metric we did was we removed the 640 patient and the average age metric. Instead of just looking at total number of Oxy 30 prescriptions, we added in there the Dilaudid, the hydromorphone 4 and 8, because those are also diverted and have a high street value. We also decided to have 2 of those metrics weighted because we thought that they were more indicative of problematic providing. So instead of each metric being weighted 1, the Oxy 30 and hydromorphone metric and the average MME per day were weighted twice. So out of the total 7 metrics, the highest score we could get was a 9. The ones weighted 2 counted as 2. The ones weighted as 1 were counted as 1. And so here's the final metrics that we've been using since 2019 to identify problematic prescribing. You can see the 2 in red, those are the ones weighted as 2 and the rest are as 1. We've provided this list in 2019, and then we were delayed at redoing this and were able to start back up with this in 2020. Delays due to internal issues, just staffing changes and stuff like that. I'm happy to discuss more, any questions that y'all may have.